All right, so let's talk now about ARDS. This is due to either direct or indirect lung injury, and that can be from trauma or that can be from some kind of sickness. What happens is an inflammatory response in the lung tissue causes the capillaries to get leaky, causes capillary permeability. So in the early stages, they have pulmonary edema. In the later stages, they may have some fibrotic changes in the lung because of that inflammation. Surfactant is inactivated. Well, remember, surfactant helps keep the alveoli inflated because it decreases the surface tension. So without surfactant, the alveoli keep collapsing and we have atelectasis. They have decreased functional residual capacity, which means decreased surface area or decreased lung capacity, and that decreases the surface area for gas exchange. Because the lung tissue is inflamed and later fibrotic, that's increased resistance. So the pulmonary artery is having to work harder to push blood through it. So they get pulmonary artery hypertension. They develop something called an intrapulmonary right to left shunt because of the alveoli that can't exchange gases. So if you think about the blood going through the pulmonary vascular system, and it's supposed to be going around those capillaries and gas exchange occurs. But then it goes, those capillaries rejoin and go to the pulmonary veins and they go back oxygenated to the left side of the heart, right? So if we have capillaries that can't exchange gases, then we have deoxygenated blood and it goes through the capillaries around those alveoli that are full, that are either collapsed or full of water or fibrotic. And so no gas exchange happens. And so that deoxygenated blood just goes back to be circulated again without picking up oxygen. That's called an intrapulmonary right to left shunt blood. It just goes deoxygenated back into the left side of circulation. That damaged lung tissue and the alveoli filled with fluid becomes a place for bacteria to grow, and so they develop pneumonia. So what are we going to see? This patient is going to begin with the signs and symptoms of pulmonary edema, so crackles and orthopnea and shortness of breath, hypoxia, right? And they're going to also have the symptoms of atelectasis. So that's collapsed alveoli, so crackles. They develop respiratory distress, and that progresses into respiratory failure. So what does respiratory failure look like? We're going to talk about that in a minute. Your patient just progressively becomes less able to oxygenate their blood. And so they may need mechanical ventilation. Medical management is supportive in finding the cause. They find and treat the cause. One of the causes for this is there are some viral infections, and this is one of the manifestations of severe COVID. This also can be caused in sickle cell by something called acute chest syndrome. I have known of a patient who was on immunosuppressants after transplant who had just a cold and developed ARDS because of that. So this is an inflammatory response in the lungs. So this patient may need ventilator support. They should get low volumes to prevent further lung injury. They need some end expiratory pressure. They need permissive hypercapnia. So that means they don't necessarily try to get the carbon dioxide level down too much while they're acutely ill. Sometimes they use something called a high frequency oscillatory ventilation. And that means instead of regular breaths in and out from the ventilator, they oscillate air in and out in smaller volumes. And so that causes less damage. They also are probably going to get diuretics because of the pulmonary edema. They're going to get vasodilators because of the pulmonary hypertension. The nurse is going to be really involved in this piece, but they balance the need for fluids to maintain enough systemic blood pressure, but so that they're perfusing all their vital organs, but also if they give too much fluid, they increase pulmonary edema and pulmonary hypertension. They may get inhaled nitrous oxide because that relaxes the pulmonary vessels to decrease that pulmonary hypertension. They may get inhaled prostaglandins for the same reason. They may end up on ECMO. The prognosis for this is improving. It used to be really terrible, but it is improving. They've learned better how to manage it. Nursing care, these patients are often prone. We monitor respiratory status, fluid balance, renal function, cardiac output, all very carefully. This is an ICU patient, okay? The acute phase of this is prolonged, so the nurse may be the person who reminds the provider, hey, they haven't been able to eat in days, so we need to get a tube in because they need nutrition support or some TPN. So nutrition support is important. We're working to prevent all the complications of immobility because they're mobile for a long time. They usually have to be sedated, and they probably are going to need, the patient and their family may need some help with processing this trauma. The next thing I want to talk about is respiratory failure, which follows ARDS really well. Respiratory failure is the inability of the respiratory system to maintain adequate oxygenation of the blood. So it may lead to carbon dioxide retention. So what do you see? Signs of respiratory distress, anxiety, or restlessness. Now, if their CO2 is going up, you may also start to see sedation. You can't wake this patient up. So if you have a patient who's obtunded, you need to be figuring out why. What you will see is that you increase the oxygen and their SATs come up with that, and then the SATs drop and you have to bump it back up a little higher, and then the SATs drop and you have to bump it a little higher. Or your patient is requiring a significant amount of oxygen and they're obtunded. You can't wake them up because their CO2 is just getting higher and higher. This can lead to respiratory arrest. It can be sudden onset, but really often this is insidious. This is not something that's just like, oh, boom, they're in respiratory failure. It's this gradual change. So medical management is obviously, if they arrest, then that patient's coded, but treating the causes, the treatments are aimed at maximizing the effectiveness of breathing and minimizing the work of breathing. So supplemental oxygen, they may get CPAP or BiPAP, and they may progress to intubation and ventilation. Nursing care, one of the most important things we can do is recognize the signs. We want to recognize when they've gone from 2 liters to 4 liters, because if we don't, then down the road, we don't want to catch this when they're about to stop breathing or when they stop breathing. Lots of support for the family. There's been a move toward including family members in resuscitation for this patient. Okay, we have one more section, and it's going to be probably the hardest.